And today, we are tackling a true giant.
We're diving deep into the body's ultimate multitasking maestro, the liver.
It is a truly extraordinary organ. It's the largest one inside you, weighing in at something like 1,400 to 1,600 grams in an adult.
That's huge.
It is. But what's really mind-blowing and essential to understanding its pathology is its blood supply. About 60 to 70% of all the blood flowing to it comes directly from the portal vein.
Which means it's getting everything straight from the gut.
Everything. All the nutrients, all the waste, and all the toxins.
That's the starting point right there, isn't it? It's absorbing the good, the bad, and the toxic, constantly processing the world we ingest. The sheer volume of chemistry happening in that single organ is just staggering.
It really is.
So for you, our dedicated learner, the mission today is a rigorous deep dive into Chapter 18 on liver and gallbladder disorders. And we're not just giving you definitions, we are decoding the visual language of liver disease.
Absolutely. Our focus is going to be heavily on morphology. You know, the relationship between structure and function. We'll be interpreting those complex serological marker diagrams for viral hepatitis.
Which can be so confusing.
They can. We'll walk through the anatomical models that explain injury patterns, and most critically, we're going to dig into the specific details you find in the H&E slides and the gross pathology images.
Because seeing the damage, that tells the real story.
It tells the full diagnostic story. Seeing the collapse of the architecture, the accumulation of fat, the patterns of scarring, that's where the understanding lies.
So we're covering the entire spectrum. We'll move from the microscopic blueprint of the cell through viral infections and chemical exposures, all the way to chronic scarring, tumors, and the mechanical problems of the biliary system.
It's a lot to cover.
It is, but we're going to structure this knowledge so it sticks, starting right at the foundation, how the liver is built.
Okay, let's unpack the structural organization of the liver. When you first learn about it, you see these two models, the hexagonal lobule and the functional acinus.
Right.
And my first question is always, if the classical lobule model already existed and mapped the blood flow, why did pathologists need to adopt this second model, the acinus model?
That's a fantastic starting point because understanding this dual architecture is the critical first step to predicting where specific injuries are going to land.
So it's about location, location, location.
Exactly. The classical lobule model, which you see in figure 18.1, is the anatomical description. It's based on landmarks.
Yeah.
You have the central vein, the CV, right in the middle.
The drain,
It's
essentially.
the drain, yes. And then at the corners of this hexagon, you have the portal triads.
The essential trio.
The tria, right. The hepatic artery, HA, the portal vein, PV, and the bile duct, BD. So the lobule describes the flow path from the periphery inward toward that central vein. So the lobule is like the historical geographic map of the city.
Precisely. Now, the acinus model, that's the physiological or functional map. It organizes the parenchyma, the liver tissue, into 3 concentric zones, 1, 2, and 3.
And these are based on blood flow.
Based on blood flow, oxygenation, nutrient concentration, and exposure to incoming toxins. And this model is superior because pathology so often respects these zones with remarkable specificity.
Okay, so let's talk about the zones. What really differentiates zone 1 from zone 3? Because knowing where the cell death is happening is a huge diagnostic clue, isn't it?
It's a massive clue. So zone 1 is the periportal zone. This is the area closest to the incoming blood from the portal triad.
Right at the entrance.
Right at the entrance. Therefore, it's the best oxygenated, and it receives the highest concentration of nutrients, drugs, and any bloodborne toxins.
So it gets the first and strongest hit of whatever's coming in.
That's right. This location makes it really sensitive to agents that are immediately toxic upon arrival. And because it's right next to the bile ducts, it's also the area most sensitive to injury from bile duct obstruction.
Okay, that makes sense. So zone 1 is the intake and processing area.
Exactly. Now you contrast that with zone 3, the centrolobular or paracinar zone.
This is the one furthest away.
Farthest from the blood supply, right next to the central vein. So consequently, it has the lowest oxygen and nutrient saturation. It's a low-flow environment, and crucially, it is rich in the phase I detoxification machinery.
The cytochrome P450 system.
The P450 system, exactly. And that is the key to so many drug injuries.
How so?
Well, these P450 enzymes metabolize many drugs, But sometimes this metabolism creates a highly toxic intermediate metabolite before the body can fully detoxify it.
And since P450 is concentrated in zone 3,
And because this zone is also susceptible to poor perfusion or ischemia, zone 3 is the classic site of injury for many predictable toxins.
like the textbook example, acetaminophen toxicity.
The absolute classic. The metabolism generates the reactive intermediate NAPQI right there in zone 3. So if you see injury concentrated right there, you should immediately be thinking about a drug or ischemic injury.
And zone 2 is just in the middle.
Zone 2 is the intermediate zone. It really only suffers damage when the injury is severe enough to bridge the damage between the two extremes. But that zone 1 versus zone 3 distinction, that is a cornerstone of understanding liver pathology.
So when a hepatocyte is under stress, a virus, alcohol, ischemia, it seems to respond in just a few stereotypic ways. What are those universal cellular hallmarks of injury that you look for under the microscope? Let's distinguish the two main types of cell death.
Right. We're primarily looking for apoptosis and necrosis, and they represent fundamentally different ways a cell dies, and each one gives you a clue about the underlying cause.
Okay, let's start with apoptosis, programmed cell death. What does that look like on an H&E slide, and what does it typically mean?
Apoptosis is, it's an orderly suicide. It's often triggered by things like viral infections like hepatitis B or C, or maybe autoimmune processes. You can see it in figure 18.2.
So what happens to the cell?
When hepatocyte commits to this, it shrinks dramatically. The nucleus condenses, we call that pinosis, and the cell actually fragments into these distinct membrane-bound sacs.
Okay.
And crucially, these sacs, the apoptotic bodies, they're immediately recognized and engulfed by the resident macrophages, the Kupffer cells. And this happens without spilling any cellular contents or triggering a wider inflammatory reaction.
So it's a very clean, contained cleanup process. And there's a specific term for these, isn't there?
Yes, pathologists often use the unique term Councilman bodies to describe these isolated, rounded, eosinophilic, meaning pink-staining apoptotic cells. They look like little shrunken spheres amidst healthy tissue.
So if you see Councilman bodies, your mind should immediately jump to something like viral hepatitis.
It should be high on your differential diagnosis, absolutely.
And what about the other kind? Necrosis. The messy, catastrophic death.
Necrosis is the result of overwhelming external injury, whether it's toxic or ischemic. Here, the cell swells up tremendously, what we call ballooning degeneration. Then the membrane just ruptures.
And spills everything.
Spills its contents everywhere, and that initiates a massive inflammatory response. That inflammation is the body's attempt to clear up all the debris. And necrosis can range from just spotty, isolated dead cells to confluent or bridging, which are large, continuous sheets of dead cells. Confluent necrosis is often associated with massive organ failure.
And when that injury becomes continuous, the body tries to patch things up. But the repair mechanism, the fibrosis, can often create a worse problem than the initial injury, leading to scarring and cirrhosis. How does that scar formation start at the cellular level?
This is the critical mechanism. This is what links chronic injury to end-stage disease.
Oh, wow.
The primary driver here is a cell type called the hepatic stellate cell. It lives in the space of Dissy.
Which is that tiny space between the blood vessel and the hepatocyte.
Exactly, separating the sinusoidal blood from the hepatocyte.
And what are they doing when the liver is healthy? Are they just sitting there?
Pretty much. Normally they're quiescent. They're basically functioning as the liver's vitamin A storage depot.
Okay.
But when chronic injury signals start bombarding them, signals like TNF-alpha, inflammatory chemokines, and especially TGF-beta, which is the master switch for fibrosis, the stellate cell becomes activated.
And what does that activation turn them into? What do they start doing?
They transform into these highly fibrogenic, contractile myofibroblasts. Their whole mission switches from storing vitamin A to just massive collagen production. They start laying down huge amounts of extracellular matrix, mostly stiff type I collagen, right into that space of Dis.
And that gums up the works.
It absolutely does. This deposition thickens the sinusoidal walls, it impedes the exchange of nutrients and oxygen, and it ultimately weaves the thick, irreversible fibrous septa that defines cirrhosis. This conversion is the engine of chronic liver failure.
So when these injury mechanisms just overwhelm the liver's massive reserve, and you have to remember, the liver can lose 80 to 90% of its function before failure is clinically apparent, what does that failure look like? Let's clearly distinguish acute versus chronic.
Okay. Acute liver failure is a rapid, catastrophic event. It's defined as failure with associated encephalopathy and coagulopathy that occurs within 26 weeks of the initial injury.
So it's fast.
Very fast. It's typically caused by a single massive assault, Overwhelmingly, that's either acetaminophen toxicity or, less commonly today, acute viral hepatitis, particularly Hep A or B.
Pathologically, what does a liver ravaged by acute failure look like? Figure 18.4 shows the gross specimen.
Figure 18.4 is the image of massive destruction. Grossly, the liver is often small, it's shrunken, and it's discolored because of massive confluent necrosis. Huge swaths of functional tissue have just been wiped out simultaneously. The patient essentially dies because the liver can't perform its core metabolic functions quickly enough to maintain life.
And that contrasts so sharply with chronic liver failure.
Very different. Chronic failure is the result of progressive, insidious chronic disease. It leads almost universally to the development of cirrhosis over months or even years. Figure 18.5 shows this end-stage morphology. A liver that's lumpy, hard, and distorted, defined by these regenerative nodules and dense fibrous bands.
So the symptoms would be different too.
Very different. The symptoms of chronic failure, fatigue, weight loss are really nonspecific until the liver just decompensates completely, which is usually when the consequences of portal hypertension kick in.
Whether the failure is acute or chronic, the clinical consequences seem devastatingly consistent. We should probably focus on what you could call the triple threat of liver failure.
Good way to put it. The first and most visible is jaundice, or icterus, the yellowing of the skin and eyes. This is simply the failure to properly process and excrete bilirubin, so it backs up into the systemic circulation.
And second, the inability to stop bleeding.
Coagulopathy. The liver is responsible for synthesizing nearly all of our circulating clotting factors. Factors 2, 7, 9, X, 7, 12, and fibrinogen.
It's a factory for them.
It is. In failure, these become profoundly deficient. This is reflected in abnormal coagulation tests, like a prolonged PTINR, and it manifests as an extremely high risk of severe, life-threatening hemorrhage, especially when you couple that with the high pressure of the portal system.
And third, the neurological consequence, which is just so clinically striking.
That is hepatic encephalopathy. This is functional impairment of the central nervous system, the CNS, caused by the failure to detoxify gut-derived toxins.
And the main culprit is ammonia.
The main culprit is ammonia, yes. Ammonia is produced by intestinal bacteria. It travels to the liver through the portal vein and is normally converted into urea. In liver failure, or when blood is shunted around the liver, ammonia bypasses this system and reaches the brain, where it is highly toxic to astrocytes.
So what are the clinical manifestations of this encephalopathy?
Well, it leads to a spectrum of symptoms, from mild confusion and altered sleep patterns all the way to severe stupor and coma. But the classic physical sign a clinician looks for is asterixis.
The liver flap.
The liver flap. It's that characteristic non-rhythmic flapping tremor of the extremities, particularly visible when the patient tries to hold their arms outstretched. It is a true hallmark of advanced liver failure.
Okay, we've covered the acute destruction. Let's now pivot to the long, slow crisis, how chronic injury turns into this permanent, debilitating architecture we call cirrhosis. So cirrhosis is the end stage for most chronic liver diseases: alcohol, viral hepatitis, inherited disorders. It's defined by an irreversible architectural collapse. What must a pathologist see, both grossly and microscopically, to definitively diagnose cirrhosis?
There are three non-negotiable morphological criteria, which are really clearly visible in the gross specimen in figure 18.5.
Yeah.
You need all three to make the diagnosis.
Okay, what's number one?
First, bridging fibrous septa. These are thick bands of scar tissue laid down by those activated stellate cells that abnormally connect the structures. They run from a portal tract to a central vein and from portal tract to portal tract.
So the original blood flow paths are completely blocked or rerouted through a maze of scar tissue.
Exactly. And the second feature is the parenchymal nodules. These are masses of hepatocytes that are trying to regenerate.
Trying to repair the damage?
Right, but because they're hemmed in and choked by this dense constricting fibrous tissue, they form distinct, isolated spherical nodules. The nodules are the attempt at repair. The septa are the failure of that repair.
And the third feature is simply the consequence of the first two,
which is diffuse architectural distortion. The normal lobular organization is just completely lost. The entire liver surface is now hard, shrunken, and nodular.
Let's focus on the microscopic view now, using figure 18.20b, which illustrates alcoholic cirrhosis. This biopsy is often stained with Masson trichrome, which highlights collagen in blue. What's the specific pattern that's common in alcoholic disease?
In alcoholic cirrhosis, we classically see a micronodular pattern. On that Masson stain, you see these small, usually well-defined regenerative nodules, generally less than 3 millimeters in diameter, that are sharply delineated by those dark blue fibrous septa.
And what does that tell you?
These small nodules indicate a diffuse injury that progress pretty uniformly throughout the liver.
The source also notes that cirrhosis from, say, chronic viral hepatitis might look a bit different.
That's right. Postnecrotic cirrhosis, which often results from viral disease, can sometimes initially feature a macronodular pattern, where the regenerative nodules are larger, maybe greater than 1 centimeter.
And why is that?
It reflects larger areas of tissue survival interspersed with massive necrosis and regeneration. But, regardless of whether the pattern is micro or macronodular, the clinical reality is exactly the same. The liver is permanently crippled and awaiting the inevitable consequences of that high pressure.
And that's the perfect transition. The most immediate and dangerous consequence of cirrhosis is the high pressure it creates in the portal system, portal hypertension. So what's the underlying pathology? Why does the pressure jump so high?
Well, portal hypertension is fundamentally an increased resistance to portal blood flow. And this resistance has two major components. The main component is mechanical. It's a fixed resistance. Those thick, unyielding fibrous septa and the large regenerative nodules, they physically compress and distort the low-pressure sinusoidal channels and the portal venules. They just block the flow.
So that's the structural problem, and the other component is dynamic.
Correct. The dynamic resistance is equally important. Remember those sinusoidal endothelial cells?
Yes.
They're normally regulated by vasodilators like nitric oxide, NO, to maintain low pressure.
Yeah.
In cirrhosis, there's a failure of NO production. This causes the sinusoidal endothelial cells to actively constrict, which increases the resistance even further.
So the blood is being squeezed by scar tissue, and the remaining pathways are clamping down. This forces the blood to back up and find new routes. Figure 18.7 is the definitive diagram showing the 4 major consequences. Let's walk through the listener's path to decompensation.
Right, so the 4 major clinical consequences are ascites, hepatic encephalopathy, which we've already covered, the formation of portosystemic shunts, and splenomegaly.
Let's start with ascites, which affects a staggering 85% of cirrhotic patients. It's the accumulation of massive amounts of fluid in the abdomen. What drives this dramatic fluid shift?
Ascites is driven by 2 cooperative failures. First, there's the mechanical problem. The immense back pressure causes a massive increase in hydrostatic pressure in the capillaries of the splanchnic circulation. This forces fluid out of the vessels and into the peritoneal space.
So it's literally being pushed out.
And second, there's the metabolic problem. The failing liver synthesizes vastly reduced amounts of albumin.
And albumin is the protein that keeps fluid in the blood vessels.
Exactly. It's the primary protein responsible for plasma oncotic pressure, which normally keeps fluid inside the vascular space. So with high pressure pushing out and low protein holding in, the fluid rapidly accumulates.
Next, the most acutely life-threatening consequence, the shunts, specifically the development of esophageal varices.
Yes. When the pressure exceeds a certain threshold, the body exploits these connections between the high-pressure portal system and the low-pressure systemic circulation, creating portosystemic shunts.
And where do these form?
These weak, dilated veins form in several key areas. Around the rectum, which are hemorrhoids, around the umbilicus, creating that striking visual sign known as caput medusae.
I've seen pictures of that. It's incredible.
It is, and most dangerously in the submucosa of the lower esophagus and stomach, forming varices.
And why are esophageal varices the killer complication?
Because the delicate esophageal veins are just not built to handle that intense, high-volume, high-pressure portal flow. They dilate, they become thin, and they're extremely fragile.
And it can rupture.
Rupture of esophageal varices causes massive, catastrophic upper gastrointestinal hemorrhage. This happens in about 40% of cirrhotic patients, and each bleeding episode carries a short-term mortality rate of around 30%. It is a true medical emergency that defines the severity of end-stage liver disease.
And finally, that congestion also impacts the spleen, causing splenomegaly.
Yes. The portal congestion backs up into the splenic vein, causing the spleen to become chronically engorged and massively enlarged, often up to 5 or 6 times its normal size.
And that has its own consequences.
It does. This persistent congestion leads to hypersplenism, where the overactive enlarged spleen sequesters and destroys blood components. This often causes a reduction in white blood cells, leukopenia, and platelets, thrombocytopenia, which further complicates the bleeding risk.
Before we move on, we have to touch upon the concept of acute on chronic liver failure, because it's a really rapidly growing clinical concern. What does this situation entail?
This is a devastating clinical scenario. It's a sudden, severe decompensation in a patient who already has stable, well-compensated chronic liver disease, usually established cirrhosis.
So they're already on the edge.
Exactly. The existing scarred liver has virtually no reserve capacity left.
And what usually pushes them over that edge?
A secondary, overwhelming insult. This could be a severe infection like sepsis, an acute drug overdose, or even a new active viral superinfection, like acute hepatitis A or B hitting a patient with established hep C cirrhosis.
And they just can't handle it.
The chronic underlying damage means they just cannot mount a recovery response to the acute insult. And this leads to rapid high mortality multi-organ failure. It just underscores the fragility of that cirrhotic state.
Let's transition now to the single most globally significant cause of chronic liver disease, the hepatitis viruses. The sheer variety in their transmission, their progression, and their serological fingerprints is what makes them so complex.
It really is.
We'll start with the relatively simple pair, hepatitis A and E.
Right. They're both small RNA viruses, and they're transmitted via the fecal-oral route, so contaminated food or water. They're classically known for causing acute liver disease, but here is a key takeaway.
Go on.
They're acute-only infections. They do not progress to chronic hepatitis or cirrhosis.
So if you get Hep A, you get sick, you recover completely, and you're immune.
That's the general rule. Now, while Hep A is generally a mild, self-limited illness, hepatitis E carries a specific, dangerous risk that you have to remember.
And what's that?
If a pregnant woman contracts Hep E, particularly in the third trimester, she has a very high risk of developing fulminant hepatic failure and death. Hep E is particularly common in developing equatorial regions.
Wow. Okay, let's use figure 18.8 to help the listener decode the serological pattern for Hep A. How do we confirm an active infection versus remote immunity?
The serology chart shows the timeline pretty clearly. In the acute phase, when the patient is sick and may be jaundiced, the diagnostic marker is the rapid rise of IgM anti-HAV.
The IgM antibody.
Right. IgM signals an active or very recent infection. As the patient recovers, the IgM declines, and IgG anti-HAV rises and persists indefinitely.
And the presence of IgG anti-HAV is the good news, meaning recovery and protective immunity.
Exactly. It's the hallmark of a successfully cleared infection or a successful vaccination.
Okay, hepatitis B is where the game really changes. It's a complex, partially double-stranded DNA virus that carries a high chronic risk, especially in the very young.
Yes, HBV is structurally very complicated because even though it's a DNA virus, it replicates using an intermediate step involving reverse transcriptase. So converting an RNA template back into DNA.
Which is unusual.
Very unusual. And it's crucial because it's the target of many antiviral treatments. Transmission is primarily parenteral. So blood, sexual contact, and critically, mother-to-child or perinatal.
Now, figure 18.9 maps out the outcomes, and the age of infection makes a profound difference in the chronic risk.
It makes all the difference. If a healthy adult contracts HBV, their mature immune system can usually clear it. You get a 90 to 95% recovery rate, only 5 to 10% progress to chronic hepatitis.
But for a newborn.
But if a newborn infant is infected perinatally, their immune tolerance is high, and they fail to clear the virus effectively. Consequently, the chronic rate just skyrockets to over 90%.
90%.
Over 90. This high criticality rate is why HBV is such a potent driver of global cirrhosis and HCC.
Now, we absolutely have to tackle the serology diagrams in figure 18.10(a) and B. This is often the most intimidating part of the entire chapter, but mastering these markers is key to clinical diagnosis. Let's contrast the profile for resolution A versus chronic infection B.
Okay. We track 3 key viral components and their antibodies. The surface antigen, HBsA, the envelope antigen, HBAG, and the core antibody, anti-HBC.
In the resolution pathway in figure 18.10a, what marker is the defining feature of successful clearance and immunity?
The hallmark of success is the disappearance of HBsAg. HBsAg is the outer coat of the virus, and its disappearance means the immune system has cleared the circulating virus.
And that's followed by the good antibody.
Exactly. Its disappearance is followed shortly by the rise of the protective antibody, anti-HBs. The presence of anti-HBs signifies recovery and protective immunity for life. We also expect to see the disappearance of HBAg, which is associated with high viral replication, and the appearance of anti-HBA.
What about the core antibody, anti-HBC? Does that go away?
No. Anti-HBC, the antibody to the core antigen, appears shortly after infection, and it persists for life, regardless of whether you resolve it or it becomes chronic. If you see anti-HBC without HBs-Ag, but with anti-HBs, that usually means a remote resolved infection.
Okay, now let's flip to chronic infection in figure 18.100b. What marker persists for more than 6 months, confirming chronicity?
The defining feature is the persistence of HBs-Ag in the serum for over 6 months. Crucially, the protective anti-HBs antibody never appears, or it only appears later in a non-replicative carrier state.
And what if the HB-Ag also persists?
If HB-Ag also persists, that indicates high viral replication and high infectivity, a very dangerous stage for the patient and for transmission risk. Even if HB-Ag is lost and anti-HB appears, as long as HB-Ag is present, the patient is still chronically infected.
Now, if HBV is complex, HCV is the silent epidemic because its progression is so frequently chronic.
It really is. HCV is a single-stranded RNA virus. And like HBV, it is primarily transmitted parenterally historically through blood transfusions. But now it's dominated by intravenous drug use.
Why is the chronicity rate for HCV so staggeringly high compared to HBV in adults? It's something like 80%, right?
Over 80%, yes. The main reason lies in the viral genetics. The HCV RNA polymerase lacks a critical proofreading capability.
So it makes a lot of mistakes.
A lot of mistakes. This rapid mutation rate generates a diverse population of viral variants, which we call quasi-species. They're constantly changing their surface antigens.
And the immune system just can't keep up.
It can't keep up with these rapid mutations to mount a sustained effective clearance response. The result is persistence. Over 80% of acute HCV infections progress to chronic hepatitis.
That is just a massive number. Let's look at the serology for chronic HCV in figure 18.1b. This is another source of clinical confusion. The antibody is present, but it doesn't mean you have immunity.
This is the crucial point. The development of anti-HCV antibodies, which usually occurs 3 to 6 weeks post-infection, is generally not protective. It only means you've been exposed.
So how do you know if the infection is active?
The true indicator of persistent infection and chronic disease is the presence of detectable HCV RNA in the serum. If that RNA is still detectable after 6 months, you have chronic HCV, which carries about a 20% lifetime risk of progression to cirrhosis and HCC.
Okay, let's ground this discussion in the visual evidence.
Yeah.
What does active viral hepatitis actually look like under the microscope?
Well, regardless of the specific virus, the general microscopic features are pretty predictable. You can see them in figure 18.3. First, you see widespread hepatocyte injury swelling, ballooning, and cell death, which manifests as both apoptosis, those Councilman bodies, and focal necrosis.
And then the inflammation.
And then you see a characteristic inflammatory response. It's usually a mixed infiltrate of mononuclear cells, lymphocytes, plasma cells, macrophages, that spill out from the portal tracts and spread across the lobule. We often call this lobular inflammation.
But the viruses do leave specific calling cards in the hepatocytes, don't they? Let's look at chronic hepatitis B and the striking ground glass hepatocyte in figure 18.42.
Yes. The ground glass hepatocyte is an excellent visual cue for chronic HBV. It's caused by the massive accumulation of the hepatitis B surface antigen, HBs-Ag, within the hepatocyte's endoplasmic reticulum, or ER.
So what does that look like on the H&E stain?
Under H&E, the cytoplasm becomes swollen and takes on this characteristic light pink or finely granular, slightly hazy appearance like ground glass.
It's essentially a cell that's just struggling so hard to process viral components that it swells up with them.
Exactly. The ER is completely overloaded. The specific location and appearance are so characteristic that while you can confirm it with a special HBs-Ag immunostain, that ground glass look on H&E is highly suggestive of chronic HBV.
Now let's shift to chronic hepatitis C in figure 18.15. What signature feature does HCV often leave in the portal tracts that pathologists use as a key diagnostic indicator?
Chronic HCV often features prominent lymphoid aggregates or follicles right within the portal tracts. Figure 18.15a and b clearly show these dense, distinct clusters of mononuclear cells.
And that's different from HBV.
It is. This clustering is often associated with the early development of bridging fibrosis. The presence of these aggregates, sometimes alongside fatty change or steatosis, is highly characteristic of chronic HCV and helps differentiate it visually from a typical chronic HBV infection.
We've established the viral damage. Now let's move to the chemical damage, the toxins and metabolic overloads that cause injury. Our liver is the body's ultimate chemical filter, making it uniquely vulnerable to drug-induced liver injury, or DILI. How do we classify the two primary ways that drugs cause damage?
The two classifications are really based on predictability. First, there's direct toxicity.
Okay.
This is dose-dependent, it's predictable, and it affects almost everyone once the toxic threshold is reached. It causes injury directly related to the dose taken and usually results in acute, severe pathology, often massive necrosis.
Acetaminophen is the textbook example. Explain that zone 3 mechanism again.
Right. When you take too much acetaminophen, it saturates the normal detoxification pathways. The liver's P450 system, which is concentrated in zone 3, metabolizes the drug into the highly reactive and destructive intermediate NAPQI.
And the body can't keep up.
The body's natural antioxidant, glutathione, is overwhelmed. NAPQI then binds to cellular macromolecules, leading to massive rapid cell death, specifically in that vulnerable zone 3. That's why zone 3 necrosis equals acetaminophen until proven otherwise.
And the second mechanism is the unpredictable time bomb.
That's the idiosyncratic reaction. This is non-dose dependent, highly unpredictable, and it involves a host factor, either a genetic susceptibility like polymorphisms in metabolic enzymes, or an immune hypersensitivity.
So it only affects a few people.
It might only affect a handful of people who take a particular drug, like certain antibiotics or the anti-tuberculosis drug isoniazid. And because it's unpredictable, the injury pattern can mimic virtually any other liver disease, from acute hepatitis to chronic cholestasis.
And Table 18.5 really drives that point home. DLI doesn't look uniform. It can look like fatty liver, hepatitis, or even vascular lesions.
Precisely. This complexity means the clinical history is paramount. If we see a pattern of cholestasis, we have to rule out a physical obstruction. But we also must ask if the patient is taking a drug known to cause cholestasis, like oral contraceptives or anabolic steroids. The morphology gives us the type of injury. The patient history tells us the cause.
Fatty liver disease, which covers both alcoholic liver disease and non-alcoholic fatty liver disease, is perhaps the most rapidly growing global health crisis impacting the liver. Let's start with the shared spectrum of progression, which we can see in Figure 18.17.
Yes, the spectrum runs in 3 stages. Stage 1 is simple steatosis, or fatty change, just the accumulation of lipid droplets in the hepatocytes. This stage is often reversible with lifestyle changes or abstinence.
And Stage 2?
Stage 2 is steatohepatitis, which is where inflammation, cellular injury, and necrosis are introduced. Stage 3 is cirrhosis, the irreversible end-stage scarring.
The difference between simple steatosis and the inflammatory phase, steatohepatitis, whether it's alcoholic hepatitis or HSH, is crucial because one is benign and the other is progressive. What specific pathognomonic features define that inflammatory stage?
The inflammatory phase is defined by a triad of microscopic findings, which you can see in figures 18.18 and 18.21. First, hepatocyte ballooning degeneration. The cells are visibly swollen and distressed from the accumulation of fat and water.
And second, the presence of Mallory-Denk bodies.
Yes. Can you describe those visual anchors again? They're so classic.
Mallory bodies are these irregular, rope-like, clumped aggregates of intermediate filaments, specifically cytokeratins, that appear as bright eosinophilic or pink inclusions in the cytoplasm of the injured hepatocytes. Figure 18.18 shows them clearly as these dense, pink tangles inside the swollen, unhappy cells. They're a sign of severe cellular stress.
A great description. And third, you see a prominent neutrophilic infiltration acute inflammatory cells clustering specifically around those injured ballooned hepatocytes. That triad confirms the aggressive inflammatory phase is underway.
The specific type of fat accumulation is also diagnostic. Steatosis is classified as macrovesicular or microvesicular.
Right, macrovesicular steatosis is the overwhelming norm for both ALD and NFLD. The large lipid droplet pushes the nucleus to the periphery, giving the cell that signet ring appearance. This is a common, often reversible finding.
And microvesicular.
In contrast, microvesicular steatosis involves numerous tiny fat droplets that fill the cytoplasm but do not displace the nucleus. This microvesicular pattern is associated with acute, devastating metabolic insults like acute fatty liver of pregnancy and signifies immediate danger.
Turning specifically to NAFLD and NASH in Figure 18.22, this is clearly linked to the metabolic syndrome, obesity, diabetes, hypertension. Figure 18.22 explains the clinical progression.
Clinically, the majority, about 80% of people with fat in their liver have simple steatosis, NAFL, and may never progress. However, about 20% develop non-alcoholic steatohepatitis.
And NASH is the problem.
It is NASH, the inflammatory necrotizing form, that significantly drives the progression to advanced fibrosis, cirrhosis, and ultimately an increased risk of HCC. And since NASH is often asymptomatic, it can be a silent path to end-stage liver failure.
The liver is also vulnerable to genetic errors that cause toxic accumulation. Let's look at 3 inherited conditions that create distinct, pathologically recognizable storage diseases. Starting with hemochromatosis, the iron overload.
Hemochromatosis is defined by excessive iron absorption, usually due to mutations in the HFE gene, with C282Y being the most common. Iron then deposits throughout the body, starting in the hepatocytes in zone 1 and progressing to the pancreas, causing diabetes, the heart, causing cardiomyopathy, and the joints.
What does that iron deposition look like in the liver? Figure 18.24 focuses on the visual pathology.
We see the deposition of these golden yellow to rust brown hemosiderin granules, that's the stored iron, in the cytoplasm of the periportal hepatocytes. This finding is confirmed pathologically using a special iron stain, like Prussian blue, which turns the iron deposits a vivid blue color.
And the iron itself is toxic.
The chronic toxicity of the iron causes continuous inflammation, leading to fibrosis, cirrhosis, and a high risk of HCC.
Next, Wilson disease, the copper accumulation disorder.
Wilson disease is a recessive disorder caused by a mutation in the ATP7B gene, which impairs the copper transport protein needed to secrete copper into the bile. So copper accumulates in the liver, leading to acute failure or chronic disease. You can see an example in figure 18.50.
And it doesn't just stay in the liver.
No, crucially, it also accumulates in the brain, causing neurological symptoms, and it deposits in the cornea, creating the classic brownish-green Kaiser-Fleischer rings, which are often the first diagnostic clue.
Finally, alpha-1 antitrypsin, alpha-1 AT deficiency. This is a deficiency of a circulating protease inhibitor. But the damage to the liver comes from the failure of secretion, not the lack of function.
That is the essential pathology. In the most severe phenotype, the PiZZ type, the gene produces a defective, misfolded alpha-1 AT protein. This protein can't be properly packaged or secreted, so it gets trapped and accumulates in the rough endoplasmic reticulum, the ER, of the hepatocytes.
And that causes damage.
This chronic retention triggers ER stress and cellular injury.
How does that trapped protein look microscopically? Figure 18.25b provides a visual fingerprint.
Figure 18.25b shows multiple, striking round to oval, bright eosinophilic cytoplasmic inclusions. They're concentrated primarily in the periportal hepatocytes. And because the trapped material is a glycoprotein, the microscopic hallmark is that these inclusions stain strongly positive with a periodic acid shift, PAS, stain and remain positive even after being treated with diastase.
And that's definitive.
That is the definitive pathologic sign of alpha-1 AT deficiency in the liver.
Let's return to jaundice. To understand how bile flow gets interrupted, cholestasis, we first need a clear mental picture of normal bilirubin processing. Let's walk through the 5 steps of the metabolic cycle using figure 18.26.
Okay. Step 1. Heme from old red blood cells is broken down, and that yields unconjugated bilirubin, UBC. This UBC is lipophilic, it's fat-soluble and toxic, so it needs transport.
Right.
Step 2. It is rapidly bound to albumin in the blood, which acts like a protective transport taxi. Step 3. The hepatocyte then takes up this albumin-bound UBC.
And step 4 is the crucial transformation that the liver performs.
Step 4 is conjugation. Inside the hepatocyte, an enzyme called UGT1A1 attaches glucuronic acid to the UBC. This conversion makes the bilirubin water-soluble, turning it into conjugated bilirubin BC.
So it goes from an oily, toxic compound to something the body can get rid of.
Exactly. It's now water-soluble and ready for excretion. And that's step 5, secretion.
Yeah.
The BC is actively secreted into the bile canaliculi, where it flows through the bile ducts into the intestine and is ultimately excreted.
So jaundice, or hyperbilirubinemia, means one of those steps has failed. Table 18.8 helps us use lab tests to localize the problem.
Right. If the patient has predominantly high unconjugated bilirubin UBC, the issue is either prehepatic, like hemolysis producing too much UBC, or hepatic, a failure of uptake, or more commonly, a failure of conjugation like you see in Gilbert syndrome.
And UBC doesn't show up in the urine.
No, UBC is bound to albumin, so it is never found in the urine.
Now, if the patient has predominantly high conjugated bilirubin, BC, the conjugation step worked. So where's the failure?
The failure is either in the secretion of EC from the hepatocyte into the canaliculi, what we call intrahepatic cholestasis, seen in hepatitis, or, most commonly, a physical obstruction of the bile ducts downstream, which is posthepatic cholestasis.
And since BC is water-soluble,
it readily spills into the urine, giving it that characteristic dark tea-like color. This is a crucial distinction.
When bile flow stops, the state of cholestasis, the liver reacts with some very strong visual pathology. What are the microscopic hallmarks of bile accumulation?
Cholestasis is microscopically defined by the presence of accumulated bile pigment. Figure 18.27 shows the key findings. The most recognizable feature is the bile plug. It's this amorphous, brown-yellowish material that's distending and plugging the bile canaliculi, clearly showing the functional blockage.
And the cells around it look stressed.
They do. The surrounding hepatocytes may be swollen, displaying a feathery or clear cytoplasm. These are cholestatic hepatocytes. We also see Kupffer cells loaded with the brown bile pigment.
What happens when there is a sudden physical obstruction of a large duct, say, a gallstone lodged in the cystic duct that causes a backup? Figure 18.28 illustrates acute duct obstruction.
Acute physical obstruction is often accompanied by a bacterial infection ascending from the gut, which leads to intense inflammation called acute cholangitis.
So what do you see on the slide?
Figure 18.28 highlights the marked bile stasis. But if you look closely at the portal tracts, they are teeming with inflammation, particularly a dense infiltrate of acute inflammatory cells, the neutrophils clustered around the bile ducts. That indicates an acute bacterial process. You also see a reactive proliferation of new tiny bile ducts, called a ductular reaction.
And if that obstruction becomes chronic, the result is secondary biliary cirrhosis, which we can see grossly in figure 18.30.
Yes. Chronic obstruction, whether from gallstones, strictures, or tumors, causes persistent damaging inflammation that eventually leads to fibrosis. The gross specimen in figure 18.30a is often stained greenish-yellow due to massive bile retention, and it is overtly nodular.
And under the microscope.
Microscopically, chronic obstruction creates fibrous septa that often have a distinct, irregular, jigsaw puzzle-like pattern of scarring, which eventually leads to end-stage biliary cirrhosis.
Next up are the two major autoimmune diseases that target the biliary tree: primary biliary cholangitis, PBC, and primary sclerosing cholangitis, PSC. They both destroy bile ducts, but in radically different ways. Let's use Table 18.2 to contrast their clinical and pathological profiles.
Okay, let's start with primary biliary cholangitis, PBC. This is essentially an autoimmune attack on the small ducts inside the liver.
Who is affected, and what are the clinical markers?
PBC predominantly affects middle-aged women, about 90% of cases. And the definitive serologic marker is the presence of anti-mitochondrial antibodies, AMA, which are found in about 95% of patients.
And pathologically, what does that immune attack look like? Figure 18.34 shows the hallmark lesion.
The hallmark is the florid duct lesion, which you can see in figure 18.34. This involves the non-suppurative granulomatous destruction of the small and medium-sized interlobular bile ducts by a dense infiltrate of lymphocytes and plasma cells. The immune system is physically destroying the functional ducts,
Leading to cholestasis and scarring.
Exactly. It's a progressive disease.
Now let's contrast that with primary sclerosing cholangitis, PSC.
PSC targets the large intrahepatic and extrahepatic bile ducts. It shows a strong male predominance and, critically, has a high association with inflammatory bowel disease, IBD. Specifically, about 65% of PSC patients also have ulcerative colitis.
The morphology of PSC is one of the most memorable visual concepts. How does the scarring present microscopically?
The chronic inflammation and injury cause this intense pathognomonic pattern of periductal fibrosis. You get these concentric layers of dense laminated collagen that deposit around the bile duct, slowly strangling the lumen.
This is the famous onion skin fibrosis.
Exactly. Onion skin fibrosis or concentric periductal scarring. You can see it in figure 18.35.
That onion skin description is so visceral, it perfectly describes how the duct is slowly choked out of existence. And radiologically, that concentric scarring leads to a unique finding, right?
Yes. The classic radiological finding, often seen on cholangiography in figure 18.36, is the beading appearance. The severe focal strictures from the onion skin fibrosis alternate with segments of dilated duct, creating this series of narrowings and bulges.
And this disease is particularly ominous.
It is because of the high risk, up to a 10 to 15% lifetime risk of developing cholangiocarcinoma, or bile duct cancer.
The liver relies on massive, uninterrupted blood flow. When that flow is disrupted, the consequences are immediate and severe. Figure 18.40 categorizes these problems based on where the blockage occurs: inflow, intrahepatic, or outflow.
It's a highly effective classification. So impaired inflow is usually due to portal vein obstruction or thrombosis. This can be caused by hypercoagulable states, local tumors, or infection, and it mainly presents as severe, sudden portal hypertension.
And impaired intrahepatic flow.
That is typically a consequence of diffuse structural disease like cirrhosis, but it also includes specific conditions like sinusoidal obstruction syndrome, or SOS.
And the most dangerous structurally are often the impaired outflow problems, where blood is trapped.
Yes, this includes passive congestion, from heart failure backing up into the liver, and the much more acute and deadly Budd-Chiari syndrome.
Let's focus on Budd-Chiari syndrome in figure 18.43, the obstruction of the major hepatic veins. How does this present grossly?
Budd-Chiari is a clinical emergency, often associated with hypercoagulable states like polycythemia vera. When the hepatic veins thrombose, blood cannot exit the liver. Grossly, as you see in figure 18.43, the liver becomes massively swollen, tense, and it takes on this striking, dark red-purple hue because of acute severe congestion and hemorrhage.
And under the microscope?
Microscopically, we see massive central lobular congestion and necrosis, a zone 3 injury, which rapidly leads to acute liver failure.
And the other severe flow problem, sinusoidal obstruction syndrome, SOS, which affects the tiniest vessels.
Right. SOS, also known as veno-occlusive disease, involves the non-thrombotic obliteration of the terminal hepatic venules. It's often seen in patients receiving high-dose chemotherapy or hematopoietic stem cell transplants due to direct toxicity to the endothelial lining.
So what does that look like on the slide?
Figure 18.44 shows the microscopic view. The central veins and surrounding venules are visibly obliterated by swollen, damaged endothelial cells, fibrin, and eventual collagen deposition. This creates intense back pressure and sinusoidal congestion.
Pregnancy can reveal metabolic vulnerabilities, leading to unique and potentially fatal liver conditions. Let's look at acute fatty liver of pregnancy, AFLP.
AFLP is a life-threatening acute condition that arises late in the third trimester. It's a severe metabolic crisis that's strongly linked to a genetic deficiency in the fetus.
What kind of deficiency?
Specifically, a deficiency in an enzyme called long-chain 3-hydroxyacyl-CoA dehydrogenase, or LCHD. The toxic long-chain fatty acid metabolites cross the placenta and just overwhelm the mother's liver metabolism.
We touched on steatosis earlier. What makes AFLP pathognomonic on biopsy compared to the common ALD or NAFLD?
The diagnosis hinges on the visualization of diffuse microvesicular steatosis. Remember the difference. In macrovesicular steatosis, the fat droplet is large and pushes the nucleus aside. In microvesicular steatosis, these tiny fat droplets uniformly fill the cytoplasm, but crucially, they do not displace the hepatocyte nucleus.
And that pattern is the key.
That diffuse pattern signifies a severe acute derangement in fatty acid oxidation, making the diagnosis highly specific.
And the liver also suffers in severe preeclampsia and eclampsia.
Yes. Preeclampsia, which is characterized by hypertension and proteinuria, can escalate to the severe HELLP syndrome, that's hemolysis, elevated liver enzymes, and low platelets. In the liver, this severe condition causes microvascular injury, leading to fibrin deposits in the sinusoids and subsequent periportal hepatocellular necrosis.
And in the worst cases?
In the most devastating cases, this can result in hepatic hematoma formation and rupture of the liver capsule, causing massive internal hemorrhage.
Let's move on to masses. When a liver mass is found, the critical distinction is always benign versus malignant. Fortunately, most focal liver lesions are benign, but their appearance can be highly misleading.
It can. Let's review the 3 most common benign lesions, emphasizing their defining morphological features. First, focal nodular hyperplasia, FNH. This isn't a true neoplasm, but a hyperplastic response to a localized congenital vascular anomaly.
What's the single most reliable gross feature for FNH? We can see it in figure 18.47a.
Grossly, the hallmark is the central fibrous scar that's visible in the center of the lesion, often with fibrous septa radiating outwards like spokes on a wheel.
And under the microscope?
Microscopically, the nodules are composed of bland hyperplastic hepatocytes, but what's pathologically important is that they lack normal portal tracts and bile ducts, although they typically have large, thick-walled arteries.
Next, the most common benign tumor, often discovered incidentally, cavernous hemangioma.
Hemangiomas, as you can see in figure 18.48, are simply malformed vascular tumors. They're typically small, discrete red-blue nodules. Microscopically, they are nothing more than large, cavernous, blood-filled vascular channels lined by a single layer of flattened, benign endothelial cells. They're almost always asymptomatic, but can sometimes be confused with malignancy on imaging.
And finally, hepatocellular adenoma, HCA, which is clinically significant due to its bleeding risk and potential for malignant transformation.
HCA is strongly associated with hormonal factors, particularly high-dose oral contraceptive use in women. Grossly, they're pale, tan masses, like in figure 18.49a.
And what's the key feature microscopically?
Microscopically, as seen in figure 18.49b, HCA consists of sheets of bland, well-differentiated hepatocytes. The crucial diagnostic feature, separating them from FNH in normal liver, is the absence of normal portal tracts in central veins, while being supplied solely by arterial flow.
The source material is clear that HCA isn't a single entity, and subtyping is essential for risk stratification.
Absolutely. The molecular classification is now standard. For instance, the beta-catenin activated type carries a much higher risk of progression to HDC and has to be managed aggressively. The inflammatory type is generally lower risk. This tells us that even in benign lesions, the underlying genetics dictates the clinical danger.
Now we move to the two main primary malignant killers of the liver, starting with hepatocellular carcinoma, HCC, which accounts for 85% of liver cancers globally. What is the overwhelming underlying condition?
The biggest single risk factor, particularly in Western nations, is underlying cirrhosis. The source states that 85% of HCC cases in the U.S. occur in cirrhotic livers, regardless of whether that cirrhosis came from alcohol, NAFLD, or chronic viral infection.
Then globally.
Globally, however, chronic hepatitis B is the dominant driver, especially in Asia and Africa, where it can cause HCC even in non-cirrhotic livers.
How does HCC present grossly? Let's look at figure 18.52a.
HCC can present as a large solitary mass or, more commonly, as multiple diffuse nodules studding the cirrhotic liver, which is what you see in figure 18.52a. The tumor often shows evidence of necrosis and hemorrhage, and sometimes the malignant cells retain the ability to produce bile, which leads to green-tinged areas. That's a key gross finding.
Microscopically, what are the classic patterns that define HCC? We need to look at figure 18.52b and 18.53.
The classic microscopic appearance is the trabecular pattern shown in figure 18.53. The malignant hepatocytes grow in these thick, disorganized sheets or cords, often multiple cells thick, that are separated by sinusoidal spaces.
Which is very different from normal liver.
Very different. Normal liver plates are one cell thick. These malignant cells show typical features: large size, abundant cytoplasm, an increased nuclear to cytoplasmic ratio, and abnormal mitotic figures.
We should also touch on the distinction between large cell change and small cell change.
Right. Large cell change involves, frankly, malignant but large, slightly disorganized hepatocytes. Small cell change is more ominous. These cells are smaller, highly pleomorphic, and grow rapidly with scant cytoplasm. This less differentiated pattern usually indicates a more aggressive tumor with a poorer prognosis. HCC is also notorious for invading local vascular structures, which is a pathway that often leads to distant metastasis.
Finally, cholangiocarcinoma, which is shown in figure 18.56, the malignancy of the bile duct epithelium. What are its major risk factors, especially PSC?
Cholangiocarcinoma is the second most common primary malignancy. Key risk factors are those that cause chronic inflammation of the bile ducts. Primary sclerosing cholangitis, PSC, is a major risk, as are chronic parasitic infections like liver flukes in endemic regions of Asia.
And what does its pathology look like? The fibrous reaction is intense.
It is. Grossly, it's characterized by a firm, hard, gray-white infiltrating mass. Microscopically, which you can see in figure 18.56d and c, it is typically an adenocarcinoma, forming recognizable glandular structures, ducts, or papillae. The key differentiating feature from HCC is the immense surrounding fibrous reaction, which we call desmoplasia.
Then that makes it hard.
This dense reactive stroma gives the tumor its rock-hard consistency, and its infiltrative nature makes early surgical resection extremely difficult, which contributes to the generally dismal prognosis.
We'll shift our focus now to the accessory organ, the gall bladder, whose main function is to store and concentrate bile. Most of its pathology really boils down to mechanical blockage and subsequent inflammation.
That's right. And cholelithiasis, or gallstone formation, is incredibly common. But the stones come in two major chemical flavors. First, the dominant type in Western nations: cholesterol stones.
What are their composition and key risk factors?
Cholesterol stones account for about 80% of stones in the U.S. They are crystalline, pale yellow, and often radiolucent, meaning they're not visible on a plain X-ray.
And the risk factors?
The risk factors are summarized by the classic mnemonic from table 18.11: female, fertile, multiple pregnancies, fat obesity, and 40, increasing age. Other factors include rapid weight loss, which mobilizes cholesterol, and hyperlipidemia.
Figure 18.58 shows that pristine single cholesterol stone cross-section. Now the other type, pigment stones.
Pigment stones are composed primarily of calcium bilirubinate. Black pigment stones are associated with chronic hemolysis, like sickle cell anemia, because the constant breakdown of red cells overwhelms the liver with unconjugated bilirubin. They're hard and oxidized.
And brown stones.
Brown pigment stones, which you can see in figure 18.6, are softer, mixed with cholesterol, and are strongly associated with bacterial infection and stasis within the bile ducts.
How exactly do these components solidify into a stone? What is the pathogenesis?
Well, gallstone formation requires a perfect storm of conditions. First, supersaturation of bile with the stone component, either cholesterol or unconjugated bilirubin. Second, hypomotility or stasis of the gallbladder, which prevents the bile from being effectively flushed out and allows time for nucleation.
And third.
And third, accelerated nucleation of the crystals, which is often promoted by hypersecretion of mucus from the gallbladder lining.
So cholecystitis, inflammation of the gallbladder, is almost always precipitated by gallstones, typically when a stone temporarily obstructs the cystic duct. What is the sequence of injury in acute cholecystitis?
The initial injury is key. It is primarily chemical, not bacterial.
That's interesting.
It is. When the stone obstructs the neck of the duct, bile gets trapped and concentrated. Enzymes within that trapped bile, particularly phospholipases, hydrolyze lecithin into a highly toxic detergent known as lysolecithin. This chemical detergent starts to irritate and damage the mucosal lining, causing intense acute inflammation.
And then the bacteria come in.
Then secondary bacterial infection often follows, which just compounds the injury.
If that inflammation persists, it leads to chronic cholecystitis. What does the pathologist see that confirms chronicity? Figure 18.61b highlights a classic feature.
Chronic cholecystitis results from repeated mild bouts or persistent low-grade irritation. This leads to severe thickening of the gallbladder wall due to fibrosis and chronic inflammatory cell infiltration, mostly lymphocytes. But the most characteristic microscopic feature is the development of Rokitansky-Aschoff sinuses, which you can see in figure 18.61b.
What are those exactly?
They are outpouchings or diverticula of the gallbladder mucosa that penetrate or herniate through the muscle wall into the underlying fibrous tissue. They're evidence of chronic, high-pressure, inflammatory injury and are the microscopic signature of chronic cholecystitis. The gallbladder becomes stiff, scarred, and unable to function properly.
Finally, gallbladder carcinoma. While relatively rare, it is often aggressive and has a strong link to the underlying chronic conditions we just discussed. What is the overwhelming risk factor?
Gallbladder carcinoma is the most common malignancy of the extrahepatic biliary tract, but its etiology is pretty clear. The single most important risk factor is chronic gallstones, or cholelithiasis, which are present in 90% of cases.
So the stones themselves are the problem?
The stones and the resulting chronic inflammation are thought to drive mucosal dysplasia, which then leads to malignancy.
And how does the malignancy typically appear? We can see that in figure 18.62.
It's usually an adenocarcinoma arising from the epithelial lining. Grossly, as in figure 18.62a, it can present either as a diffuse, infiltrating thickening of the wall or as a large exophytic mass projecting into the lumen. Prognosis is generally poor because the gallbladder wall offers little resistance to invasion, and symptoms often don't appear until the tumor has already infiltrated the liver or spread widely.
Wow, that was a true comprehensive deep dive. We moved from the microscopic zones of oxygenation in the liver lobule through the complex serology of chronic viral infection, right up to the causes of fatal hemorrhages and cancers driven by high pressure.
It's a lot.
The sheer variety of ways the liver and gallbladder can fail is astonishing, but the underlying mechanisms, necrosis, inflammation, accumulation, and that irreversible fibrosis, they just keep repeating across dozens of different diseases.
If we connect this to the bigger picture, what's truly fascinating is how much the patient's exposure history, their viral contact, their dietary decisions, alcohol intake, and deep genetics, is physically imprinted on the liver's architecture.
You can literally see it.
You can see it. Seeing ground glass cells in the hepatocytes, the eosinophilic tangles of Mallory bodies, or that telltale onion skin fibrosis around bile ducts. It tells a specific detailed story that no single lab test alone can convey. Pathology is the ultimate integration of patient history and outcome.
So let's leave you with the 3 major takeaways that tie this dense material together for you, our learner.
Okay. First, remember that cirrhosis is strictly defined by the combination of regenerative nodules and connecting bridging fibrosis. This specific architectural collapse is the mechanical engine that drives the lethal consequences of portal hypertension. Varices, with their risk of fatal hemorrhage, and ascites that massive fluid accumulation.
Second, always understand the distinction in the viral hepatitis spectrum. Hep A and E are acute and self-limiting. However, Hep B and C carry an enormous, often silent risk of chronic progression to cirrhosis and HCC, and this risk is traceable through specific serology patterns, such as the persistence of HBsAg or detectable HCV RNA.
And finally, remember that morphology is highly predictive and diagnostic. Specific microscopic findings often provide the single best clue for distinct critical diseases. The presence of Mallory bodies points strongly toward alcoholic or nourish hepatitis. The demonstration of diffuse microvesicular steatosis suggests acute fatty liver of pregnancy. Morphology guides diagnosis and subsequent patient management.
We spent a lot of time today on the metabolic disorders like NAFL, DAY, and NASH, which are quickly overtaking alcohol and chronic viruses as a leading cause of chronic liver disease in developed nations, tied directly to the global metabolic crisis.
It's a huge problem.
It is. So considering the liver's constant, intimate exposure to everything that passes through the gut, the food, the environment, and the entire microbiome, here's a final provocative thought for you to explore on your own. What specific, as yet unidentified inflammatory signaling pathway, or what subtle genetic variation might be the secret switch that accelerates the progression from simple, benign fatty change to the aggressively inflammatory and scarring phase of NASH, making it such a potent modern driver of end-stage liver disease worldwide?
The liver is clearly an organ that never stops informing us about the state of our bodies and our environment. We encourage you to keep diving into this essential material.
Until next time, stay curious and keep learning.